Back, everybody, to the part 2 of the medical series, emergency series. I shall do my best to not make into a theory class, but there's only so much I can do to keep you glued to your chairs. So let's begin then. We as dentists must be prepared to manage medical emergencies which may arise in practice. Different types of medical emergencies can occur, which we as dentists have to manage on our own if no physician is available at the time, which is almost always the case. The most common medical emergencies are, number one, fainting spells, followed by respiratory distress, such as asthmatic attack, hypoventilation, then convulsions, and followed by chest pain, which may be due to angina pectoris, acute myocardial infarction, or even cardiac arrest. And finally, we have the allergies presenting as anaphylactic shock and drug-related emergency, such as overdose. Just to mention, they may occur hypoglycemic episodes as well, and diabetic coma and acute adrenocortical insufficiency as a medical emergency, but they are infrequent. The acronym SPORT, this has already been previously discussed in detail in part 1 of the medical emergency series. Let us just go through it once more so as to get it imbibed in order for us to be able to prepare for any medical emergency to be handled in an organized and composed manner. The S stands for stop treatment, P is for positioning patient, O is for oxygen. In case of, and oxygen is contraindicated in cases of hyperventilation, and of course reassurance is very important, not just for the patient, for yourself, and also for the staff of the dental setup and the patient attenders, and finally to take the vitals. We have a case scenario number 1 wherein there is a 57-year-old female arriving at a dental office with a severe toothache that was diagnosed as pulpitis. And the medical history is significant for only type 1 diabetes and poor dental hygiene, which is secondary to a lack of insurance. She had no known allergies, and there's no collateral history available. And the treatment option given by the attending dentist is either extraction or root canal treatment. The video which you are about to see is a role play of the case scenario. With all due respects to the video by Dr. Lee Brookman and his YouTube channel, and let's begin then. Immediately after the procedure, there's a patient. Our patient starts complaining of dizziness, shortness of breath, and tightness in her throat. She then falls back on the chair. First thing to be done is check for responsiveness, and if there is no response, then call for assistance. While positioning the patient in a more comfortable position to begin the necessary management protocol, we need to check for any airway obstruction and deal with them appropriately. It is very important to elevate the legs so that the blood flow gets back to the brain. And if the patient is still unresponsive, then it is time to activate the emergency response code and dial for EMS or 999 or 911. We then mobilize the oxygen cylinder and begin to administer high flow oxygen at the rate of 15 liters per minute. And then we make sure that confirm that the call has been taken place for the emergency medical response with appropriate updates of the current situation. Then we begin the overall examination, such as we check for respiratory rate, breathing pattern, and also we attach the oxygen saturation monitor if we have one. Now consider the color of the patient while looking for chest movements. It is very important to have someone document what's happening as it happens, to update the paramedics to ensure accuracy of the times during doses and condition of the patient. Now it's also important to check blood pressure if you have the equipment, and feel the skin temperature, rate the level of consciousness, check sugar levels, and if patient is conscious, ask them to move the limbs for any signs of weakness. But when the paramedics come, update them about the airway, breathing, circulation, disability, and the patient's medical history. Now, coming to the summary of this case scenario, in case the patient is having a fainting spells, first thing we do is stop treatment, make situation safe, position patient flat with leg elevation. We assess patient using airway, breathing, circulation, disability, and the exposure approach. and then also we make sure that we have already called for help. Now we immediately start high flow oxygen with correct fit mask using algorithms to remind us of treatment guidelines if the patient doesn't recover quickly. Then we have to be prepared to hand over the patient when the paramedics arrive, and then it is very important to document the scenario as it happens, when it happens, and we finally debrief the staff after the event. Now on examination, this patient was found to have a decreased level of consciousness. She had perioral edema and a racing pulse. The glucose was normal on a chemical strip, and then she roused slightly when given the intramuscular epinephrine. Now, before becoming pulseless, her pulse returned and she became responsive to the first shock of automatic electrical defibrillation. Now, let's move to the second case scenario, wherein we have a patient who is 37-year-old male arriving to a dental office for a dental checkup. The medical history of the patient was nothing of significant, and he had fair dental hygiene. He had no known allergies, and there was no collateral history available. The treatment option was given as simple class 1 restoration. Again, this video you're about to see is just a role play of the case scenario of anaphylaxis, and then all due credits to the video to Dr. Lee Brookman and his YouTube channel. Immediately after the procedure, once the patient is reassured and then the patient is spoken about the treatment protocol, and then the patient is just about to leave the dental chair, the patient complains of itchy skin, and he develops a diffuse patchy rash and watery eyes and then runny nose. He feels nauseated and complains of stomach cramps, and he gives a slight dizziness, and there's a shortness of breath and then tightness in his throat, and then the patient is unable to complete the sentences in one breath. And then he gets wheezy, which is suggestive of airway problem, and then this warrants the call for assistance immediately, and then the first thing to be done in such a case is start straight away with high flow oxygen. Now we mobilize the emergency kit, and then we mobilize the oxygen cylinder and begin to administer the high flow oxygen at the rate of 15 liters per minute. And this high flow oxygen supply is then followed by 10 puffs of salbutamol or albuterol through a spacer, and then we continue to begin the overall examination of the patient, such as the respiratory rate, and then we also attach the oxygen saturation monitor if we have one. Now, it is very important to consider the color of the patient while looking for chest movements or while everything is happening there, and then make sure to confirm that the call has been made to the emergency medical services with appropriate updates of the current situation. Now, while the updates is happening, we have to prepare for 0.5 milligrams of epinephrine to be given intramuscularly. And then meanwhile, it is very important to have someone document what happened as it happened to update the paramedics to ensure accuracy of times, the drug doses, and condition of the patient. It is also important and pertinent to check blood pressure if you have the equipment, and also feel for the skin temperature. It is also important to check for capillary refill time, check the level of consciousness using a GCS score. We check the sugar levels, and if the patient is conscious, ask them to move the limbs for any signs of weakness. We check for pupil reaction to light in case the patient is unconscious, and then it is very important to check for exposure of the patient in a dental setup, which might be difficult, and while maintaining the dignity of a patient, we expose the patient to look for signs of rashes, bleeding, injury, and bruises. The salbutamol can be repeated as necessary with a second dose of 0.5 milligram epinephrine. When the paramedics come, it is very important to update them about the airway, breathing, circulation, disability, and her patient's medical history. Now, coming to the summary of this, if you have a patient whom you think is having an anaphylactic reaction, the first thing you do is to stop treatment, make situation First thing you do is stop the treatment, make situation safe, surroundings safe, and then assess the patient with a structured airway breathing, circulation, disability, and exposure approach. Then call for help, and then start high flow oxygen with correct fit mask, and prepare for 0.5 milligrams in ratio of 1:1000 epinephrine, which can be given every 5 minutes with salbutamol puffs from a spacer. The use of algorithms to remind us of treatment guidelines if the patient doesn't recover quickly, and then hence we have to activate the emergency response early, and then we have to prepare for handover and debrief the staff after the event. We have a third scenario wherein we have a 27-year-old male being treated for a class 2 restoration. The medical history he gives is a type 1 diabetes mellitus, and he's on insulin, and then he has a fairly good dental hygiene. He had no known allergies, no collateral history is available, and then the treatment option given by the attending dentist is simple class 2 restoration. Again, let us see this hypoglycemic episode in the video, and then all due credits to Dr. Lee Brookman and his YouTube channel. And then when the patient arrives at the setup, and the patient, when you're evaluating the patient, there is sudden difficulty in breathing, and then the patient has incomprehensible and then sudden movements, and then the patient becomes very uncooperative, and then the patient talks incomprehensible, and then that's when we know we have to stop the treatment procedure, and then we have to make the surroundings safe. We have to reassure the patient, we have to check for the breathing, and then we have to position the patient back. We have to call for assistance, and then in case there is a loss of consciousness of the patient, or the patient tends to become unresponsive at this state, what we need to do is we mobilize the emergency medical kit, we call for the emergency medical response, and then we start high flow oxygen at the rate of 15 liters per minute, and then we begin the overall examination, such as the respiratory rate, the monitoring the chest movements, and then we also make sure that the call for the emergency medical response has been updated with the current situation. And then meanwhile, we prepare 1 milligram of glucagon to be injected intramuscularly. And then it is very important for someone to document what happened as it happened, to update the paramedics to ensure accuracy of the times, the drug doses, and the condition of the patient. Meanwhile, the blood pressure has been monitored, the skin temperature has been checked, we are checking for capillary refill time to assess the disability, the rate and the level of consciousness has been assessed, sugar levels have been monitored, and if the patient is conscious, we ask the patient to move the limbs to assess the signs of any weakness. If at any time the condition deteriorates, then we have to stop the patient, we have to go back, reassess the airway, position patient, and use an airway adjunct such as oropharyngeal airway, such as the Girdle airway, and then we position the airway into the mouth, and then we never force the airway adjunct into the mouth, and then we continue the high flow oxygen. Exposure of the patient in a dental setup again might be very difficult, and then we have to maintain the dignity of the patient meanwhile, and then we check for any signs of rashes, bleeding, or injury, or even bruises. And then the only thing we can do is wait for the glucagon to work and repeat the dose of glucagon if necessary while waiting for the paramedic. Now, when the paramedics come, we have to update them about the airway, circulation, disability, and his medical history. In summary, if you think a patient is having a hypoglycemic episode, the first thing we do is stop the treatment, make situation safe, assess patient using structured airway, breathing, circulation, disability, and exposure approach, and then we immediately call for help. We start high flow oxygen level with correct fitting mask at the rate of 15 liters per minute. Then we prepare 1 milligram of glucagon to be given intramuscularly. And the use of algorithms to remind us of treatment guidelines if the patient doesn't recover quickly. And then we activate the emergency response system, prepare for handover, document, and then debrief the staff after the event. Coming to the fourth case scenario, we have a 40-year-old male attending the dentist for a biannual checkup. And the medical history he gives is he has a history of allergy to pollen, and he is a known asthmatic. The other collateral history is not available, and the treatment option given by the dentist is only for evaluation and checkup. Again, the video you're about to see is a role play of the case scenario of an asthmatic attack, and then all due credits for the video to Lee Brookman and his YouTube channel. And then when the patient arrives at your setup, immediately during the procedure, he gets restless and then very jittery. Now, the first thing we do is call for assistance and prepare the emergency kit. Now, we have to ask the patient in case if he is carrying inhaler in his pockets, because we already know from his history that he is an asthmatic patient. And in case of a non-availability of the inhaler from the patient, we can use one from our own emergency kit. And because the patient is unable to complete sentences at this state, we know that the airway is compromised. Now, it is important and pertinent to activate the emergency medical response. We mobilize the oxygen cylinder and then begin to administer at the rate of 15 liters per minute, which is then followed by 10 puffs of albuterol, or which is also known as salbutamol, through a spaced reservoir. Now, it is very important to ask the patient to take deep breath while inhaling the bronchodilator and then continue the oxygen flow. Make sure to confirm the call has been made to the emergency medical services with appropriate updates of the current situation. Now we further begin with the overall examination, such as the respiratory rate monitoring, and then we attach oxygen saturation monitor if we have it, and then we consider the changes in the color of the patient while looking for chest movements. Meanwhile, it is very important to have someone document excuse me, what happens as it happens, to update the paramedics to ensure accuracy of timing, drug dosage, and the condition of the patient. Now we check for the pulse, check blood pressure if you have the equipment, also feel the skin temperature, check for capillary refill time, rate the level of consciousness, and then check sugar levels. And if the patient is conscious, ask them to move the limbs for any signs of weakness. If the patient can't do so, check for pupillary reaction to light, and then we can repeat the salbutamol inhalation if necessary. If at any time the condition deteriorates, then we have to stop the management. We go back, reassess the airway, we position the patient and use an airway adjunct such as an oropharyngeal airway of appropriate size. We never force the oropharyngeal airway or the Gibbons airway into the mouth. And then again, exposure of the patient in a dental setup might be difficult, and it is very important that we maintain the dignity of the patient while checking for any rashes, bleeding, injury, or bruises. Again, while waiting for the paramedics, when the paramedics come, we update them about the airway, breathing, circulation, disability, and patient's medical history. In summary, if we think the patient is having an asthmatic episode, what we do is we stop the treatment, make situation safe. We assess the patient using structured airway, breathing, circulation, disability, and exposure approach. We call for help, start high flow oxygen with correct fit mask, included by 10 puffs of salbutamol, and then we follow the algorithms to remind us of treatment guidelines. If the patient doesn't recover quickly, then we have to call the emergency medical services, and then we have to prepare for the handover of the patient. And then also it is very important to document and then debrief the staff after the event. Coming to the case of fifth case scenario, we have with us a 45-year-old female attending the dentist for a dental assessment and replacement of missing teeth. Patient has a history of seizures, and then again, there's no collateral history available, and then the option given by the treating dentist is evaluation and checkup. Again, the video you're about to see is a role play of the case scenario, and then all due credits to Dr. Lee Brookman and his YouTube channel. And then while evaluating the patient begins to stiffen up with sudden jerky movements. In this case, we have to stop all procedures, make the surroundings safe, and then we call for assistance, and we prepare the emergency kit. It is difficult to do the airway, breathing, circulation, and disability approach while the patient is fitting. Hence, we have to start with the oxygen delivery ASAP. It is better not to place anything in the mouth, as that would lead to more injury and further blockade in the airway. And then it is very important and pertinent that we time the seizure, check for the history of her normal seizure time, and if it is mentioned in the previous history, and we continue the oxygen at the flow rate of 15 liters per minute. If the patient becomes unresponsive, we have to activate the emergency medical responses and services, and then we continue the oxygen flow. Make sure that the call for the emergency medical services already been done with appropriate updates of the current situation, and then we ask the assistants to prepare 10 milligrams of midazolam, which can be given transbuccally or intramuscularly. It is also important that while giving the injection midazolam 10 milligrams transbuccally, to clear the secretions from the mouth to avoid aspiration and complicate the situation. And once the midazolam 10 milligram has been given, and then the patient appears to be stopping the seizures, the episode of the seizure, we have to consider an oropharyngeal airway if she can tolerate it. And then as usual, we never force the airway if it doesn't fit. And then we begin the overall examination, such as the respiratory rate, and then we attach the oxygen saturation monitor if we have it. And then we consider the color of the patient while looking for the chest movements. It is also important to have someone document what happened as it happened, to update the paramedics to ensure accuracy of the times, drug doses, and condition of the patient. We check for the pulse, the blood pressure if you have the equipment. Otherwise, we just feel the skin of the temperature. We check for the capillary refill time, and then we rate the level of the consciousness of the patient. It is also important to check the sugar levels, and if the patient is conscious, we ask the patient to move the limbs for any signs of weakness. And again, exposure is very important, exposure of the patient. And then while maintaining the dignity of the patient, we expose the patient to look for signs of rashes, bleeding, injury, or bruises, while waiting for the paramedic. Now, when the paramedics come, we update them about the airway, breathing, circulation, disability, and the patient's medical history. In summary, if you think that the patient is having an episode of seizure, the first thing we do is stop treatment, make situation safe. We do not restrain the patient or put anything in their mouth, and then we call for help. We start with high flow oxygen at the rate of 15 liters per minute with correct fit mask, and then it is important to time the fitting duration and prepare 10 milligrams of buccal midazolam. And if the patient continues to fit more than 5 milligrams, 5 minutes duration, we have to repeat the dosage of the midazolam. And once the patient stops fitting, we assess with the airway, breathing, circulation, disability, and the exposure approach. We use the algorithms to remind us of the treatment guidelines. We ensure that the emergency medical services have been appropriately and early called, and then we prepare for handover, and documentation is very important. And then finally, a debriefing of the staff after the event. Coming to the final case scenario, we have with us a female patient in the 50s attending to dentist for dental assessment and for replacement of missing teeth. Her medical history states that she has cardiac issues, and then with a recent history of chest pain around 7 months back. And then likewise, there's no other collateral history which is available. And then the treating dentist gives her an option of evaluation and checkup. Again, this video is a role play of a chest pain, and then all due credits to Dr. Lee Brookman and his YouTube channel. And then while the patient walks in, patient walks in, the patient is being monitored, and then the patient is taken of the history.
Okay. How am I?
I'm so sorry, I think I have technical issues with the video, and then I'll just talk you through the scenario. And then this patient is, while sitting in the chair, the patient begins to have sudden jerky movements, and then this patient complains of uneasiness and then heavy feeling in her chest, and then pins, and she also complains of pins and needles going up and down her chest. Now, upon further asking, she says it's not exactly pain, but pressure. and mostly towards her left side. The first thing we do is prepare the emergency kit and then start high flow oxygen at 15 liters per minute in order to maintain her saturation levels. It is important to call for early assistance, and then while assessing her breathing pattern and level of difficulty and discomfort. We also activate the emergency medical system services, and then we continue the oxygen flow with the rate of 15 liters per minute, and then we give appropriate updates of the current situation to the emergency medical services while on call. We are also attaching the oxygen saturation monitor if we have one, and then we look for any changes in the color and also for the chest movements in case there are normal or abnormal chest movements. And then if the stats look abnormal, then we have to prepare for a sublingual nitroglycerine spray and two sprays with followed by 300 milligrams of chewable aspirin tablet. Meanwhile, it is very important to have someone document what happened as it happened, to update the paramedics to ensure accuracy of times, the drug doses, and condition of the patient. The blood pressure and then the pulse has been monitored, and then we feel for the temperature of the skin, check for capillary refill time in the disability section, and then we also rate for the level of the consciousness, and then we monitor the sugar levels, and then if the patient is conscious, we ask the patient to move the limbs for any signs of weakness. If at any point of time the patient becomes unresponsive, we have to stop, go back, and then reassess the airway, and then we position the patient flat. We clear the secretions from the oral cavity, and if the patient doesn't breathe normally, then we have to activate the code blue, and we have to prepare for the CPR or the BLS protocol. And then it is important to redial the emergency medical services to check for their location. And then since the patient is in cardiac arrest, we have to start with high efficiency compressions, and then we continue CPR while waiting for the paramedic to arrive. Again, when the paramedics come, we have to update them with the airway, breathing, circulation, disability, and the patient's medical history, such as the recent history of chest pain past 7 months ago. And in summary, if you think the patient is having an episode of chest pain, we stop the treatment, we make the situation safe, we assess the airway, breathing, circulation, disability, and the exposure approach. We call for help early, and then we start high flow oxygen with correct fit mask. Sublingual nitroglycerine with 2 sprays and 300 milligrams of aspirin chewable tablet is been administered, and then we start early CPR. And in case there is a handy automatic electrical defibrillator, we use it, and then we shock the patient if needed, while using the algorithms to remind us of the treatment guidelines. We finally prepare for the patient to be handed over to the paramedics when they arrive. We document everything, and also after the episode, we debrief the staff after the event. The next slide, coming to the emergency drugs. Drugs are not necessary for the immediate management of the most emergencies, but the primary management of all emergency situations is basic life support. The emergency kit is a simple organized collection of drugs and equipment that have been found to be highly effective in managing those life-threatening situations, which require the administration of certain drugs. Now, the drugs that should be promptly available to the dentist can be divided into 2 categories, that are injectables and non-injectables. And in the first category, the injectables, they are further divided with 3 subcategories, such as the which considered as primary or essential drugs. The second category is containing the drugs secondary or non-essential drugs, and finally the third category, the drugs for advanced cardiac life support. Now, the non-injectables include the oxygen cylinder, the vasodilating agents, the respiratory stimulant, the anti-hypoglycemic agents, and bronchodilating agents. The precise composition of the drug kit can vary as the presence of the drugs in this group may depend on the nature of the dental setups. Coming to the individual drugs, the injectable drugs, there are either primary essential, secondary non-essential, and cardiac emergency drugs. And then under primary essential drugs, there are epinephrine, antihistamine, narcotic antagonists, and anticonvulsants. The secondary or non-essential drugs are analgesics. such as morphine sulfate, or the vasopressors, the corticosteroids, and then antihypoglycemics, and finally the drugs for advanced cardiac life support include sodium bicarbonate, lidocaine, and atropine. The drugs for advanced cardiac life support, I will not go into detail basically because these drugs, a set of drugs, are beyond the scope of today's presentation. And then we will just focus on the primary essential and then the secondary non-essential drugs individually. The first drug, coming to the first drug, is the epinephrine, and then the properties as it has good and rapid onset of action. It is a potent action as a bronchodilator, and then it is also has antihistaminic properties with vasopressor properties. There are certain side effects with this drug, which this predisposes the heart to arrhythmias, and then also it is relatively a very short duration of action, usually lasting up to 5 to 10 minutes if given intravenously. And then the indications of epinephrine is cardiac arrest, anaphylaxis, or an acute asthmatic attack. And there are certain precautions which need to be taken in it should not be used in treatment of shock because it can decrease the venous return with increased ischemia. Therefore, there is a high risk of to the patient for development of ischemic heart disease, and it can also precipitate ventricular fibrillation. It should also be used with caution in pregnancy, as it decreases the placental blood flow and may induce premature labor. The rationale for the use of epinephrine for cardiac arrest is it stimulates the beta stimulation of the myocardium, and then it is available as a parenteral administration in the dosage of in the concentration of 1:1000 or even 1:10,000 concentration each ml. And then the administration is, it can be administered by IV or intracardiac route. Also, the dental personnel may give it into the frenum under the tongue. The dose is ranges from 0.3 to 0.5 milligrams of solution, which is given subcutaneously or intramuscularly. Coming to the second emergency drug, this is antihistamine, and then the drug of choice is diphenhydramine. And then the alternatives to diphenhydramine are chlorpheniramine maleate and phenramine maleate. The indication is it is used in delayed allergic reactions in which onset of symptoms is more than 1 hour after the administration of any allergens. Now, there are certain precautions again, and then this is have to be caution in the management of acute asthmatic episodes, and also the side effects of antihistamines are it causes CNS depression, and then it leads to decreased blood pressure, and also it causes thickening of the bronchial secretions. Hence, therefore, it is contraindicated in asthmatics. The availability of chlorpheniramine maleate is 10 milligrams to 20 milligrams per ml in every 1 ml of ampule or 2 ml of ampule. This is also available in 1 ml preloaded syringe. And then the diphenhydramine is available in the dosage of 25 to 50 milligrams per ml, and it is available in 10 and 30 ml multi-dose vials, and also 1 ml preloaded syringe is kept ready in the emergency kit. The suggested for emergency kit is 3 to 4 ampules of any of the two, either diphenhydramine or chlorpheniramine maleate. Coming to the anticonvulsants, the drug of choice in anticonvulsants is diazepam, and then the alternative for diazepam is midazolam or benzodiazepines. And the action is the diazepams are the barbiturates. They terminate the seizure activity without any pronounced depression of respiratory and cardiovascular system. And then likewise, they have certain side effects such as the respiratory depression, and they are available in the dosage of 5 milligrams per ml. And then administration is always, it should be administered IV or IM. The indications are such as the status epilepticus, local anesthetic seizures, or even hyperventilation in case we need sedation, and in case of thyroid storm also, we can use this drug for sedation purposes. The availability of midazolam is again 5 milligrams per ml in 1, 2, 5 and 10 ml vials, and also 2 ml preloaded syringes. The fourth emergency drug is the antidotal drugs, which are the first among of the antidotal drugs, the first one being the narcotic antagonist, and then the choice is naloxone. And if either morphine is included in the emergency kit or opioids are used to as a part of a sedation regime, then naloxone should also be present for the emergency management of inadvertent overdose. The doses should ideally be titrated slowly in 0.1 milligrams increment to effect. The alternative drug to naloxone is nalbuphine, and then the indication is these are pure opioid antagonists, and then it is the drug of choice for any opioid-induced apnea or narcotic-induced depression. The action is more than one administration can be needed because the action is very short duration of time, and then administration is it is given intravenously but can also be given subcutaneously or intramuscularly. The side effects also include acute withdrawal syndrome, and in such cases we have to give the titrated dosage, and then for adult dosage we give the dosage of 0.4 milligram per ml in 1 ml ampule, and for a pediatric dose it is 0.02 milligrams per ml in 1 ml ampule. Moving ahead to the second antidotal drug, which is benzodiazepine antagonist, and then the choice of drug is flumazenil. And the side effects of the flumazenil as it causes rebound anxiety, and then it is indicated in the reversal of sedation. It is available in the dosage of 0.1 milligram per ml in 10 ml, and then multi-dose vials. And then this antagonist flumazenil should be a part of the emergency kit when oral or parenteral sedation is used, as these techniques are usually based on effective use of benzodiazepines. And the dosage can be arranged from 0.1 to 0.2 milligrams intravenously, incrementally given. And the suggested kit, dosage, the units for emergency kit is up to 2 vials, either of the flumazenil. And coming to the secondary injectable drugs, the first one under the secondary injectable drugs is analgesic drug. The drug of choice in this category is morphine sulfate, or the alternative is meperidine. The indication is acute myocardial infarction, the congestive heart failure, or intense prolonged pain and anxiety. Likewise, like all drugs, this also has some side effects which include CNS and respiratory depression, and then it is also contraindicated in victims of head injury and multiple trauma. It is also to be used with care in patients with compromised respiration, and then the respiratory depressant action by these drugs can be reversed by the use of naloxone, and then it is available in the dosage of 8, 10, and 15 milligrams per ml in 2 ml ampules and 20 ml multi-dose vials. The meperidine is available in 50 and 100 milligram per ml in 1 ml ampules and 20 and 30 ml multi-dose ampule vials. Recently, there was a mixture of 35 to 50% of nitrous oxide and oxygen, which was used in place of narcotics in the management of chest pain associated with myocardial infarction. The rationale is it provides the victim with 2.5 times to 3 times more ambient levels of oxygen compared to the other analgesic drugs. The second drug is the vasopressor drug, and then the drug of choice in the vasopressor category is the methoxamine or phenylephrine and the ephedrine. The alternates are methoxamine and phenylephrine, whereas the choice is ephedrine. And then the action is it is an adrenergic agonist. It produces mild increase in blood pressure due to peripheral vasoconstriction. And the indications are acute adrenal insufficiency, drug overdose, hypotension, and allergic reactions. There are certain precautions to be taken, and then these ephedrine is used in caution with in patients with hyperthyroidism or patients with bradycardia or even partial heart block patients, the myocardial disease, and also atherosclerosis patients. The dose of methoxamine is 10 milligrams per ml, and phenylephrine is 10 milligrams per ml given either IV or intramuscularly, whereas ephedrine is 5 milligrams per ml given incrementally. The drug vasopressor, which is used to manage the significant hypotension, it has similar cardiovascular actions. compared to epinephrine, except that ephedrine is less potent and has a prolonged duration of action. The action lasts from anywhere between 60 to 90 minutes, and then similar precautions have to be taken with epinephrine administration, such as when given in patients with ischemic heart disease. The treatment of severe hypertension, it is ideally administered in 5 milligrams increments intravenously or intramuscularly. It should be given in a dose of 10 to 25 milligrams. These vasopressors are used only as a last resort, only after the other measures to raise the blood pressure, like the trundling blood position, has failed. And then it is very important that these vasopressor drugs are diluted before use. Coming to the corticosteroids, the drug of choice under this category is hydrocortisone sodium succinate. The alternatives are dexamethasone, and then the indications are mainly used in allergic reactions to prevent recurrent episodes of anaphylaxis. They're also important in the management of acute adrenal insufficiency or acute adrenal crisis. And then the action is, it has a very slow onset of action, and then the availability is in the dosage of 50 milligrams per ml in every 2 ml vial. And then the most common is decadrone, which is available as 4 milligrams per ml. And then the suggested units per kit is 2 to 4 vials. Moving ahead to the anti-hypoglycemics, the drug of choice is 50% dextrose solution. The alternative is glucagon. And indications for anti-hypoglycemics is to manage hypoglycemic episodes, and the administration is either IV or IM. If it is for glucagon, then we give IM, and then the side effects, and then there are certain contraindications with the use of anti-hypoglycemics, such as the liquid carbohydrate preparations should not be used in patients with diminished gag reflex, and then the parenteral administration is recommended in these situations. The presence of this drug allows for intramuscular management of hypoglycemia in an unconscious patient. The ideal management of severe unconscious patient is in a diabetic emergency is the intravenous administration of 50% dextrose, and then glucagon is also indicated if an intravenous line is not in place, and then venipuncture is not expected to be accomplished. As may often be the case in a dental office, that not everybody is professionally well equipped or well trained to perform a venipuncture procedure. Now, the dosage for an adult of glucagon is 1 milligrams if the patient is less than 20 kgs, and then the recommended dose is 15 milligrams, 0.5 milligrams glucagon when available in different formulations. The suggested unit of kits for the kit is 2 to 4 vials. And then coming to the non-injectable drugs, the oxygen. This is the most important drug in emergency and actual sense. And then patient with chronic obstructive pulmonary disease should be given with caution, because apnea may result, and then oxygen is indicated for every medical emergency except hyperventilation. This should be done with a clear full face mask for spontaneous breathing patients, and a bag valve mask device for the apneic patient. Therefore, whenever possible, with the exception of the patient who is hyperventilating, oxygen should be administered, and in case of management of a medical emergency, it should not be withheld for the patient with chronic obstructive lung disease. Even though they may be dependent on low oxygen levels to breathe, there are chronic carbon dioxide retainers. Short-term administration of oxygen to get them through the medical emergency should not deprive, in order to prevent the depression of the drive to breathe. And then again, oxygen should be available in a portable source, ideally in a E-type cylinder, which holds over 600 liters of oxygen. And then this should allow for more than enough oxygen to be available for the patient until resolution of any medical emergency event, or even until the transfer of the patient to a hospital. If a typical adult has a minute volume of 6 liters per minute, then this flow rate should be given as a minimum. And if the patient is conscious or unconscious yet spontaneously breathing, oxygen should be delivered by a full face mask, where flow rate of up to 10 liters per minute is appropriate for most adults. If the patient is unconscious and apneic, it should be delivered by a bag valve mask. where a flow rate is 15 liters per minute, which is appropriate. The positive pressure device may be used in adults, but then it is again provided that the flow rate does not exceed 35 liters per minute. Now the indication says any medical emergency in which response medical respiratory distress is evident. The second type of non-injectable is the vasodilator. Drug of choice is nitroglycerin or amyl nitrate, and then it is also available in the injectable forms. And then the indication is to manage acute chest pain or acute myocardial infarction, and also acute hypertensive episodes. The contraindications of this drug is in hypertensive patients, and then when this drug is placed sublingually or sprayed onto the lingual soft tissues, this acts in about 1 to 2 minutes. The shelf life of nitroglycerin is up to 6 weeks once exposed to air, and so the drug should be replaced every 6 weeks in the emergency kit. Now, the translingual spray has a longer shelf life compared to the tablets, and then the amyl nitrate, which is another the alternative of the trinitroglycerin, is available in use as an inhalant. This produces the vasodilation in approximately 10 seconds compared to the trinitroglycerin, which takes up to 1 to 2 minutes, and then there is a relief of pain should occur within minutes. If necessary, this dose has to be repeated twice or more in 5-minute intervals, and then we have to check for the systolic blood pressure. If below 90 millimeters per mercury, then this is contraindicated for the use. And then the availability of the trinitroglycerin is ranging from 0.1 to 0.6 milligrams, and then available in the form of spray, vapors, or even injections. Again, there are certain side effects with this drug, which are namely transient pulsating headache and facial flushing, and also hypertension, which is more evident with the use of amyl nitrate. Coming to the respiratory stimulant, the drug of choice in this category is the aromatic spirit, aromatic ammonia spirit, and this is used to treat syncope. This is used to treat syncope, and then the action is it is an irritant which causes the irritation of the upper respiratory tract, and resulting in the stimulation of the respiration and also the blood pressure. The contraindications of the usage of the aromatic ammonia spirit is in case of asthma, and also in case of chronic obstructive pulmonary disease, basically because it may precipitate the attack of asthma. And then it is very important, and then it's very funny if you read the label here that the spirit of ammonia is also used to ward off evils. And then this is available in the form of gray silver vaporules with 0.3 ml. And then the uses is for inhalation dose in the form of inhalants, the adults and teenagers. The inhalant should be held away from the face, and the vaporule is crushed between the fingers, and the inhalant should not be held for more than about 2 minutes. And then for children, the use and dose must be determined by the doctor. And then for the inhalation of the dosage in the solution form, the adults and teenagers, after the top is taken off the container, the vapor may be slowly inhaled until the patient awakens or no longer feels faint. Again, for the children, the use and dose must be determined by the doctor. Coming to the bronchodilating agents, the drug of choice here is albuterol or salbutamol. The alternatives of salbutamol is epinephrine or metoprolol or isoprolol, and then they are a type of selective beta-2 antagonists, such as the salbutamol is the first choice for the management of bronchospasm. And then when administered by means of an inhaler, it provides selective bronchodilation with minimal systemic cardiovascular effects. And then the effects of this drug reach its peak in about 30 to 60 minutes with a duration of effect of up to 4 to 6 hours. And then the adult dose is 2 sprays which have to be repeated as necessary, and then pediatric dose is 1 spray repeated as necessary. Again, the indications are the management of bronchoconstriction and then severe allergic reactions. And then the side effects include the cardiovascular side effects like tachycardia and ventricular dysarrhythmias. Coming to the aspirin is acetyl salicylic acid is one of the more newly recognized life-saving drugs, as it has been shown to reduce the overall mortality from acute myocardial infarction. The purpose of this of its administration during an acute myocardial infarction is to prevent the progression from cardiac ischemia to injury to infarction. There is a brief period of time early on during a myocardial infarction episode where the aspirin can show this benefit, and then for emergency use there are relatively few contraindications, and they would include these would include non-hypersensitivity to aspirin or severe asthma or even history of significant gastric bleed. The lowest effective dose is not exactly known with certainty of aspirin, but a minimum of 162 milligrams stat dose should be given immediately to any patient with pain suggestive of acute myocardial infarction. As in the case of the video demonstration, the dose given was 300 milligrams chewable tablet. Coming to the other final injectable drugs for advanced cardiac life support, these drugs are noteworthy of a mention in this presentation, but are actually beyond the scope of general practitioners unless they are trained in the advanced cardiac life support. The drugs which include are sodium bicarbonate, atropine, nitrous oxide, lidocaine, and amiodarone. The sodium bicarbonate is effective in the management of metabolic acidosis. This elevates the pH of blood by combining with hydrogen in the blood, and then the dosage of sodium bicarbonate is ranging from 300 to 500 milligrams of 5% sodium bicarbonate given intravenously. And we're talking about atropine. This is a parasympathetic drug. This decreases the vagal tone, and then it is indicated in sinus bradycardia associated with symptomatic hypotension. The precaution is this atropine is not indicated in patients with myocardial infarction. And then nitrous oxide is a reasonable second choice if the morphine is not available to manage the pain for the myocardial infarction. And for the management of pain, again associated with myocardial infarction, it should be administered with oxygen in a concentration approximately 35% or titrated to effect, have its beneficial effect. Now talking about the final drug, amiodarone, this is the antiarrhythmic medication used to treat and prevent a number of types of irregular heartbeats, which include ventricular tachycardia, ventricular fibrillation, and wide complex tachycardia, as well as atrial fibrillation and paroxysmal supraventricular tachycardia. To conclude, the extent of the treatment by the dentist, this requires the preparation, prevention, and then management as necessary. And then the prevention is accomplished by conducting a thorough medical history with appropriate alterations to the dental treatment as required. The most important aspect of nearly all medical emergencies in the dental office is to prevent or correct insufficient oxygenation of the brain and the heart. And therefore, the management of all medical emergencies should include ensuring that the oxygenated blood is being delivered to these crucial organs. In today's dental practice, it requires more than just knowledge and skills. It expects the clinician to be up to date and be able to deliver high quality standard and evidence-based patient care. And now that you have seen it, be prepared to manage it. Thank you very much. And we are open for doubts and queries. Back to you, Dr. Ali.
Jazakallah khair. Dr. Nyer, can you turn off your screen share, please? And I would request Nadeem to unmute himself as well. Thank you, Dr. Nyer. This was elaborate and very, very, very fruitful for all the clinicians, especially when they are practicing dentistry in their day-to-day schedule. And to experience such medical emergencies is not an easy task. And the most important thing is not to panic, as you mentioned. You need to check.
I also apologize for the technical glitches in the case scenario number 6, wherein the video did not play for some reasons. I think maybe the video would be.
That's fine. That's absolutely fine. I think it has been great. I would ask Dr. Salman to unmute himself as well, so that we could start off with the questions and panel.
Assalamu
alaikum. Yes, we can hear you. So I'll leave you to guys to it. I'm just going to stop my video and mute myself. Nadeem, it's all yours. Thank you.
Assalamu alaikum once again to all the people. MashaAllah, once again, no doubt, fantastic presentation, Dr. Nyer. Absolutely fantastic. Lot of drugs learned, lot of drugs relearned today. Didn't know much of the uses, and Alhamdulillah, I think we have jotted down most of the points. I think let me start with few. I think one of the most basic questions I think Dr. Asim Basha has asked today. I think the last question asked in the last webinar was, mashallah, a tough one. I think this time he asks, loosening of belt and removal of shoes, is it not included? So basically, when the patient is having any kind of reaction or any kind of medical emergency, is this a normal protocol we should include, loosening of the clothes and the belt and the shoes, Dr. Nyer?
When we are talking about any medical emergency, the first thing we have to remember is the acronym SPOT. And then it is also pertinent for us to actually maintain the surroundings and then check for any harmful effects such as loose electrical fittings or any inflammables or any chemical irritants which can harm the patient. And then the loosening of the belt, removal of shoes is not actually a part of the management of medical emergencies. But in terms of, I don't know, I'd say the idea of maybe the loosening of the belt or the removal of the shoes is to check for the disability such as the presence of rash, bleeding or injury to the patient so that we can assess the disability of the patient or even any anaphylactic response to the drugs given during the dental procedure.
Yeah, I think the reason he's asking is since Dr. Nyer and Dr. Salman, you people, mashallah, practice in a country where there is a lot of hijab. So for a patient, for a woman patient in particular, she lands up with a medical emergency. And since she's wearing, she's fully clothed in the form of burqa. So during these emergencies, there is profuse sweating. So she needs to be ventilated. So in that case, what exactly do you do?
Of course, in such situations, in such scenarios, it is very important to loosen the clothing so that the patient feels at ease, and then the regulation of the temperature is monitored.
So I think it is one of the important protocols to be followed. Can we term that as an important protocol during the emergency?
Loosening of the clothing is important, yes, but loosening of the belt.
Okay, okay. So probably he would have, just in a nutshell, he is just asking the belt and the shoes. Probably the clothing would have been the apt word. So I think keeping the...
but then it is really difficult to actually expose the patient in a dental setup, but then it's very important for us to maintain the dignity of the patient while exposing the patient. Okay. And it is important if it is a female patient that to have a female dental assistant around so that she handles the patient in a way that the patient gets comfortable, and then after the management of medical emergency, you don't land up into any legal issues. In conservative societies and then in setups where I practice.
Right. Dr. Salman, is your video on, yeah?
No, I've just kept it off.
Right.
Sorry.
No issues, no problem. I'll come to the next question, and this next question is to Dr. Salman. In particular, when you're doing any kind of any surgeries or minor oral surgeries for any medically compromised patients like diabetes or hypertensive or thyroid-related issues, you prefer to see them early mornings or early morning appointments? What exactly appointments do you prefer? Is it better to do with an early appointment?
Actually, in this situation, that early morning appointments are preferred because you are fresh, and I think so the patient also will be fresh and she'll be having her food and all these things. And they will be, it's better that they will not go in for hypoglycemia or anything, any complication or anything. So it's better you have it in the first appointment, just to finish off all your medically compromised patients.
Don't you think sometimes first appointment is also scary for the patient? The first patient, she's the first patient walking in and her heart rate is already pumping in because thinking that, she's the first patient into the practice. So isn't it advisable to, wait for some time or a half an hour or an hour or so and come into the procedure?
See, if there is something like that, we always make the patient, we always have a time to calm the patient down, make her sit or make him sit in the reception area, and get comfortable. And then I asked my nurse and all to check the status of the GRBS and all these things and the pulse. And if everything is within parameters, then we get the patient inside the clinic.
Dr. Nyer, any preferable medical condition you prefer to operate in the morning hours?
I think in my setup, they have absolutely no, particular time as to when to book the patient, because they just book the patient randomly, and then we have to manage every patient as a medical emergency patient, and we have to handle accordingly. The idea behind booking a patient either early in the morning is basically to overcome the diurnal variations of the regular vitals in case of medically compromised patients. Otherwise, it doesn't really matter as long as you are maintaining the stress reduction protocol in your dental setup, and then you are reassuring the patient, and then you're not hashing up the procedure, or you're not putting the patient at tensing up or tension or undue duress or anxiety.
Okay, you were speaking about the oxygen support in patients who require as an emergency backup. So the question is something related to this. Imagine you're doing a procedure, a sinus lift procedure or a maxillary sinus. There's an opening in the sinus and the patient needs oxygen. So how exactly is it delivered to the patient? Because since the sinus is opened intraorally.
What exactly are we worried about even if the sinus is open? I mean, are you worried about the sinus being open extensively, more than 5 millimeter or even up to 10 millimeter? Most of the sinus openings are less than 5 millimeters, which get obliterated by the clot, the blood clot. The immediate the flow of the blood causes the fibrinogen to get activated, and then formation of the clot, they obliterates the sinus opening, and then I think the first thing we do is we initiate the high flow oxygen levels. I think the patient life is more important than the open sinus.
Okay, so there is no way that some amount of oxygen is leaking out through that sinus opening?
It doesn't
matter. It doesn't matter
because the capacity of the maxillary sinus is 10 cc.
Okay.
As long as the patient is ventilated, I think
oxygen rate of 15 liters per minute.
Right.
Even if the leakage of around 10 cc, it doesn't really matter.
Right. Dr. Iftikhar asks, can you elaborate on capillary refill time, Dr. Nyer?
The capillary refill time is assessed by checking the nail beds. You press the nail of the patient, and then you time the time the duration in which the time taken for the blood to flow back into the nail bed. It ranges anywhere between 2 to 3 seconds. If it is delayed, then you have to worry, think about any peripheral vasoconstriction or the other issues, underlying causes.
How reliable is this?
This is very reliable. In case of COPD patients, the capillary refilling duration is extended.
Okay. In case, I think before we do that, we need to check all the fingers for nail polishes or any kind of coloring agents on the fingernails.
Of course, I agree with you.
Of course.
Okay. Does it hold good for the toe nails also, or any nails? Or does it differ from the fingernails, hand fingernails to the toe fingernails? Does it differ?
I'm not exactly aware of it, but then I can check it.
But usually we check for the hand nails for the capillary filling.
I mean, the most
accessible
area when the patient is in front of you is the hands and not the legs.
In case, that's what my query is. In case if the fingers are, nail polished or any coloring agent where the toenails are exposed, is there a way out that we can check on the toenails also?
I think
nowadays we have pulse oximeter. No, we can just keep the pulse oximeter and check the.
But pulse oximeter will not give you the apt readings, even if if there is a coloring agent, Dr. Salman. It gives you a very
can put it in the leg. You can use it in the leg, like this one also, like toes and all these things. Pulse oximeters.
Like this, not every clinic has a pulse oximeter now. Maybe now because the corona pandemic, everybody is gotten into the scare psychosis, and then they are made to buy unnecessary equipment. But then, if you have it, it's good. Of course, it's good.
Can you please elaborate why you feel pulse oximeter is unnecessary? You just mentioned it as an unnecessary equipment. Why do you feel?
No, in a private setup, what exactly are you looking at? I mean, it's a hospital setup, it's a different story altogether. Yes, you're looking at the vitals, you're looking at the oxygen stat, it's a different story. But then we are talking about, when I say it's not necessary, it's not an actually emergency element in the emergency kit, because it's a private practice, what exactly are you looking at?
Don't you think this device is a key marker to know your saturation levels in the present pandemic now, at the present practice I'm talking about?
How accurate are these devices in the present scenario is what my contention is. I mean, there was a video online, I think a couple of weeks back, wherein the pulse oximeter was fixed to a pencil, and then it showed the saturation levels of 87%. I mean, does the pencil have any oxygen levels? I mean,
because I think it was, a faulty oximeter, or probably, not a reliable one.
I'm not authenticating or giving a testimonial of that video. I'm just saying that we do not know how accurate the machine is. I mean, the ones which are portable and then they fixed with the fingers directly, unlike the monitors which we have in the hospitals.
But probably I might contradict with this statement, Dr. Nyer, because at the present scenario, I think the oximeter has saved thousands of lives for most of the people. Please correct me if I'm wrong. I'm just contradicting your answer for this. Apologies for my argument on this. So because pulse oximeter has really gone way beyond the normal expectation, even for a general physician or a general practitioner for the present scenario, where I think.
Yeah, the only thing the pulse oximeter done is made everybody diagnosed.
Right. Coming to the next question, what is the best site of intramuscular injection in case of emergencies? Some suggest anterior lateral aspect of the thigh. Is that so, or you suggest any other different site which is much more reliable?
It doesn't really matter, basically, because in case of emergency, you just have to find a bulk muscle such as a deltoid or buttock, and then you just have to inject it. You don't even have to remove the clothing. You just have to inject it through the clothing, no problem.
Okay, fine. I think Dr. Asim asks again, in case of hypertensive patients, the BP surge is more in the mornings. So don't you think it is apt to, give appointments in the afternoon times?
If there is a high BP, which is noted in my clinic, I send the patient back to the physician. I don't entertain him much, because the risk of complications are more than accepting the patient.
Right.
What do you say, Dr. Nyer? What do you think?
I agree with you, because if we already know that the patient has a history of hypertension, the first thing we do when the patient comes is, irrespective of the time or the duration of the day, we check the blood pressure, or we monitor the blood pressure of the patient, and then we assess, and then we take a call whether the blood pressure is under control or within normal limits, so as for us to continue with the dental procedure. If it is above the limit which we have a cutoff, and then we have to refer the patient back to the physician, so that the patient gets his blood pressure levels controlled.
What exactly you mean cutoff? What exactly are we looking? What window are we looking at? Systolic, diastolic?
Sorry, before I just wanted to interfere here. What about routine dental procedures? I mean, surgical procedures, of course, you have to, you might be right in probably turning the patient away back to this physician with regards to the blood pressure. But what about routine procedures? If they want to have just a filling, or
we are
say, because I think
routine dental procedures, I don't think so. It's an absolute contraindication.
Exactly.
To manage a patient with high blood pressure,
exactly.
It all depends.
You need to take care not to inject vasoconstrictors in such patients. There was a controversy.
Would it make any difference if it's just a local infiltration?
No. Absolutely not. Absolutely not.
Yeah.
Because
so you are okay to see a person with high blood pressure who's actually taking medications for it, for routine dental procedures, giving local infiltration rather than, trying to do blocks. Would that be right?
There is no contraindication for routine dental procedures. There's absolutely no absolute contraindications in hypertensive patients. But in case of surgical procedures, yes, you have to be careful. And then Yes, yes, Dr. Salman, you want to add something to this?
No, actually, the basic call is taken by the dentist, whether he is comfortable doing the procedure. But from our side, I don't think so. There's anything that extra need to be done for a simple filling with a local infiltration. There's nothing contraindicated in that. Dr. Nyer.
Thank you.
If I can add a point here, actually there was an old school of thought which said the vasoconstrictor are contraindicated in patients with hypertension. But then the new school of thought says there is absolutely no contraindication for the use of vasoconstrictor in the hypertension patients. The idea behind avoiding vasoconstrictor was the presumption that there was a secondary vasodilation in cases of the patient having undergone a surgical procedure with the vasoconstrictor, leading to prolonged bleeding. But then the concentration of vasoconstrictor being used, which may lead to secondary vasodilation and then prolonged bleeding, is very minimal, is what the latest evidence states.
Absolutely. Absolutely. Because if you have an anxious patient waiting in the room, I think the amount of adrenaline released in its own indigenously is a lot more than what we use.
I think this is why the activation of, the use of the stress reduction protocol is very important in private practice. Like I think Dr. Nadeem can have a big presentation on soft skills.
Right. I have a query. You mentioned about usage of 0.3 to 0.5 milligrams of adrenaline. How much of maximum dose of adrenaline can be given to the patient till help arrives?
Dr. Salman.
Dr. Salman?
Don't remember the exact number, but I think so. It is 2 mg. What is it?
Isn't it based on what is your response time, the ambulance response time in each country? Because you generally inject 0.5 ml on the, as Dr. Nyer said, on the anterior lateral or any thick muscle, and you wait. You give about 5 to 10 minutes time, and then you check the patient, and definitely after that much of adrenaline, he is going to be stable to a certain extent. If they don't respond, then you give another 0.5 ml. And that is for people who are 12 years and over. Between 6 to 12, you give 0.3 ml. And anybody who's below 6, it's 0.12, which is very rare, or 0.15. But this is the protocol we use in the UK.
So what's the maximum
and the response time for most ambulances is under 4 minutes. So by that time, they will come, you're meant to give the oxygen, you're meant to give 0.5 to 1 ml. There's nothing called as maximum dosage, because the moment you give maximum dosage, they'll die of heart attack. That's for sure, because the heart will start pumping and working really hard. But you're treating an anaphylactic reaction here, and the patient will surely show some response by the time you give your second dose, which is after about 5 minutes. So by that time, your ambulance should be there, and they should be taken into secondary care. This is for general practitioners.
In most of the developed nations, the response time is less than 5 minutes. I think
under 4 minutes, basically.
4 minutes, yes. And
we are talking about a nation. We are talking about a
5 to 10 minutes.
Yeah, I'm talking about a nation like India, where the response time is nothing less than 15-20 minutes. So my query still holds good, as what Dr. Mubarak said. Pumping a lot of adrenaline, definitely the patient is going to collapse. So my query is, when should I limit myself the dose of adrenaline?
First thing is, in such a case scenario, first thing is we inject the patient, put the patient in a vehicle, and then start driving back to the hospital. We don't wait for the emergency response to come to us. We take the patient directly to the emergency medical services.
And the next query is about nitroglycerin. You just mentioned about usage of nitroglycerin sublingually and contraindications where it should not be used. Now, sometimes you have few patients where patients are anemic, and that is an incidental finding that patient is anemic sometimes. So that patient particularly goes into some medical emergency, and you happen to give nitroglycerin. Isn't a nitroglycerin contraindicated in anemic patients, Dr. Nyer?
No, first thing is, what medical emergency are you, assuming that the patient will go into if the patient is anemic? I mean, see, the thing is, there are only 6 medical emergencies which are most commonly occurring in the dental system. In case you have a patient with anemia, and then what is a medical emergency that you are assuming that the patient will end up into?
So probably, she's got increased tachycardia or something, and she gets into...
Anemic patients already have tachycardia. They are already tachycardic. pulse rate is on the higher side.
Okay. Okay.
So if it is a surgical procedure, we postpone it. If there is any other procedure which is minor and which can be done without much of bleed, you can go ahead and do it.
Because I was just talking about the contraindications. I don't know. I had just read it, so I'm not.
Contraindication for nitroglycerin is hypotensive patient. Anemia is a contraindication for nitroglycerin.
Yeah, it's highly contraindicated in anemic patients. So that's what I had read about. And the second thing is the ABC.
Is it an absolute contraindication, GTN, in anemic patient?
I'm not sure about absolute, but I've just read it as contraindication. I'm not sure about it. Is it relative or absolute? I'm not sure about it. So I just read it as a
the reason I'm asking is that is the first line of protocol for an angina patient, yeah. And you're only going to give like 2 puffs in the sublingual region. So 2 puffs, would that cause any problem, or would it cause anything for the patient's anemia?
I think Dr. Nyer would be the better person to answer this.
I think one of the reasons might be, the nitroglycerin, this may lead to the oxidation of the hemoglobin and then thereby exacerbating the anemia. I don't know. I'm not sure.
Yeah, correct. Nitroglycerin, what happens, the hemoglobin, I think it gets converted into methemoglobin or something. Yeah, and it causes, something, I vaguely remember that. Okay, there's one question just popped in. How do you manage a patient on steroid therapy if needed corticosteroid? Dr. Salman?
Actually, we give him a shot of hydrocortisone before we start off the procedure. If the patient, you have the rule of 3, I think so for this. 3 weeks of continuous steroids within 2 weeks of continuous steroids.
Rule of 2, if I'm not wrong.
Rule of 2, sorry. Rule of 2,
yeah.
2 weeks of continuous steroids within 2 years of time. So in this type of patients, I give 1 shot of steroids before they come into my, before I start any major procedures with them. Like,
what exactly do you mean by 1 shot of steroid? What exactly you mean by 1 shot
like
of steroid?
dexamethasone 8 mg IV. Yeah. Or you can double the dose, like double the dose of what she is taking, or he or she is taking, the patient is taking.
Okay. One more emergency drug, what you mentioned, Dr. Nyer, about hydrocortisone. If not hydrocortisone, dexamethasone.
Right. Yes.
Yeah. So,
what is the question again? Dr. Nadeem, I think I lost you. What is the question again?
I think Dr. Nadeem's thing has stuck. You want me to repeat the question? How do you manage a patient on steroid therapy if needed corticosteroid?
We double the dosage. We ask for the dosage the patient is put on, and then we just double the dosage. For example, if the patient gives a history of 10 milligrams of steroid being taken, we make it to 20 milligrams. If it is 5, then we make it 10 prior to the procedure, 1 hour before surgery.
Okay, I think that concludes the question answers. Let me just go through it one last time. Yeah, I think that's about it. But thank you very much, Dr. Nyer and Dr. Salman, for your valuable time. Let's conclude this session because we will be finishing with our web series for this year. Inshallah, if things go fine, next year we will begin again with a new set of series. But thank you all. Thank you, Dr. Firdoose. Thank you, Dr. Salman. And thank you, everyone, for coming through.
Thank you, everybody.
I think there's a hand raised by Dr. Iftikhar.
Just a moment. Okay, Dr. Iftikhar, I'm just going to ask you to unmute. Could you unmute yourself?
No, it was not a question. It was just a praise, clap reaction. That's it.
Oh, okay.
Oh,
Thank you.
Yes,
thank you all.
Yeah.
Inshallah, we will post the recording in the main group soon. Thank you. Jazakallah khair.
Thank you so much. Thank you, everybody.